Hello and welcome to this session led by the Arrhythmia Academy on behalf of, supported by Radcliffe. My name is Jonathan Behar, cardiologist from London, UK, and I'm delighted to welcome you to this session on leadless pacemakers. It's been a really exciting development of pacing in the last few years with miniaturization of pacing technology, and I'm delighted that we have two international speakers who have been particularly involved with leadless pacing over the last decade, and I'm going to introduce them to have a discussion about where we sit in terms of the current evidence base for leadless pacing and the exciting future horizons. So firstly, I'm delighted to welcome Dr. Paul Roberts from the University Hospital Southampton in the UK. He's going to talk about the current evidence base for leadless pacing and where we are at the moment. Dr. Roberts, the screen is yours. Thank you.
Thank you very much. So I'm going to give a little bit of background of where we're at in terms of the experience and evidence base with leadless pacing. So the first device, leadless device, was the NanoStim device, and that was subsequently acquired by St Jude Medical, who were acquired by Abbott. And that was first implanted in December 2012, and more than 1,400 of these devices were implanted before implants were stopped due to some reports of premature battery depletion. The second leadless device to be implanted was the micro device, was the first implant in Linz in Austria in December 2013. And to date, there's now been about 150,000 of these devices implanted worldwide. So that's where we really take our evidence base from, is from the micro device. But the exciting news is that there's two other devices that have just started recruitment to investigational trials. So the Boston Empower device, with the first implant occurring in 2021, and the Evere device, which is an Abbott device, which is particularly exciting because this represents the first true dual chamber device, with the smaller device implanted at the right atrial appendage, and then the other device implanted in the right ventricle. It's important to recognize that the penetrance of leadless pacing is very variable. And the United States is quite unique in that greater than 50% of their single chamber devices now are leadless devices. And if you compare that to Europe, Middle East, and Africa, and the United Kingdom, those figures are very significantly different. And that is probably most largely driven by reimbursement. So the first evidence that we had regarding the micro device was the investigational study that was published in the New England Journal of Medicine. The main headlining features of that were that this was a highly effective procedure with greater than 99% successful implantation rates. However, it's always important to look at the complication rates. And we can see that the overall complication rate with the investigational study was 4%. This was largely driven by access issues. So this is a large catheter, and also pericardial effusion and perforation. And we'll focus on that a little bit more later on. However, the post-approval registry arguably was a little bit more real-world data rather than an investigational study. And we can see that there was learning from the investigational study with adaptation of the implantation process. And we can see that the major complication rate had reduced. We can still see a perforation and infusion rate, but again, it's significantly less than the investigational study. And also, importantly, there were 3 infections in this study, all of which were treated with antibiotics, and there was no long-term consequence for the device. And overall, this represented a 63% reduction in major complications compared to traditional transvenous pacemakers. The electrical characteristics of the micro device have been remarkably consistent. So we can see, looking at pacing thresholds in these 2 studies and going out to 18 months on the right-hand side, the pacing thresholds are very low. And that's particularly important as the pulse width is 0.24 milliseconds compared to traditional transvenous devices where the default is 0.4 milliseconds. And we can see sensing, if anything, improves with time, and impedances are stable. So it's important to look at these complications when compared to transvenous devices, because the rationale behind leadless pacing was to try and reduce complications associated with leads and the generator. And we can see, compared to a historical control cohort of patients receiving transvenous devices and the Cantillon study, which was a reimbursement study from the States, and also the follow-pace data, that the investigational study and the post-approval registry demonstrate very competitive complication rates. There's been a large focus on the risk of cardiac perforation with leadless pacemakers. And this meta-analysis studied the incidence of perforation or pericardial effusion in the literature, and the blue graph represents transvenous devices. And we can see that the original IDE study for the nanostim device and the micro device highlighted here. And then if we bring in the post-approval registry, we can see that that complication appears to compete very favorably with transvenous devices. In an attempt to try and understand this a little bit more, we've published data combining the IDE study, the post-approval registry, and also a small number of patients in the continued access study in the United States to look at the incidence of pericardial effusion, which was 32 across that whole cohort of 2,800, and looking at some of the demographics. And what we can see from this, using a multivariable logistic regression analysis, is a scoring system which allows us to understand what the individual risk may be for our patients. And so those that are at higher risk are those that are elderly over 85, low body mass index, females, history of heart failure, previous MI, pulmonary hypertension, COPD, and patients on dialysis. And importantly, if we also look at the number of times that we try and deploy the device. So if we look at those scores in low risk, medium risk, or high risk, we can see that the more times we try and deploy the device, the greater the risk of effusion is. So the message of this is to try and get the first deployment correct to try and reduce your risk of that as a complication. And so excitingly, the micro has moved on from being a single chamber device to being able to sense the atrium. So this is the micro AV device, which uses the signal generated by the three-dimensional accelerometer to be able to sense atrial activity. And this has been studied in the MASS2, and MARVEL studies, where software was downloaded onto the VR device, and there was an ability to look at that A4 signal, which represents atrial contraction, and then sequentially pace the ventricle. And at rest or relatively sedentary activity, this is highly successful. And when the patient exercises, the device mode switches to VVIR to maintain adequate rate response. So what we've seen after these initial studies is that physicians are tending to move to particular patient cohorts where they feel that leadless pacing is particularly attractive. One of those cohorts is patients at risk of infection, as it appears that these leadless devices are highly resistant to developing infection. And we can see here from 2,500 patients studied, there were 21 episodes of systemic infection, including 3 that resulted in endocarditis, but none of those patients ended up having infection actually related to the leadless pacemaker or the need to extract that device. The exact reason for this is unknown, but it may well be this encapsulation that you see on the left-hand side of the screen, which probably occurs around about 12 months for full encapsulation, then isolates that device from the systemic circulation. So the risk of bacteremia endocarditis associated with it is low. And that's also translated now into us seeing a high usage of leadless pacemakers in patients who have had previous cardiac device-related infections. And we can see there's 105 patients in which this was used. And what we can see is that just over a third of these patients had a micro device implanted on the same day as the extraction. We can see variable use of antibiotics, but there was no patients who had specifically subsequently micro-related infection. So this appears to be quite an attractive strategy for managing some patients where we extract infected transvenous devices. It certainly appears to reduce hospitalization antibiotic use and the risk of reinfection. Another high-risk cohort for infection and complications are the hemodialysis population. So with transvenous leads, we see that there is a high complication rate, and this is usually related to venous access due to multiple cannulation for dialysis and high rates of infection because of the ongoing risk of multiple cannulations for dialysis sessions. So Leadless appears to avoid these complications. And what we can see from the data in terms of the bottom line is that the risk of major complications with micro in a dialysis population is still relatively small. It's more than non-dialysis patients, but overall this is small and low compared to a conventional transvenous population. We've also seen the use of leadless pacing in specific niche groups. And one of these is the patients with cardioinhibitory vasovagal syncope. And this study looked at the UK experience fairly early on in our leadless experience. And what we saw from a number of different centres is that individual physicians were seeing the potential benefit of using leadless pacing in a young patient cohort who are perhaps going to use the device very infrequently for episodes of cardioinhibitory vasovagal syncope. And we can see from this, this slide here that the success rate of this follow-up was that 87% were free from symptoms and very little in the way of major complications with a reasonable time of follow-up. And this has been also further emphasized by this US study of 24 micros being used in exactly the same indication and compared to conventional dual chamber pacing in vasovagal syncope with no difference in the incidence of syncope. So demonstrating this may be a reasonable option in young patients. Now, sometimes these devices need to be revised or retrieved. And we can see here from the analysis of the micro studies, 10 patients who required system revisions. What we can see from this is that there's various different strategies to this. In some situations, the device is attempted to be removed, but in many situations, because the device is very small, it's just programmed off, and then either another micro device is implanted or a conventional transvenous device is implanted. And because of the problems with the nanostim device and premature battery depletion, we do have quite a lot of experience of extraction off the nanostim device. This study looked at the comparison of nanostim extractions and micro extractions. And the procedure for taking them out is slightly different. So with the nanostim device, the end of the device needs to be captured, and then there needs to be rotation to withdraw the helix from the endocardium. Whereas with the micro device, the device just needs to be gripped and pulled, and the nitinol tines flex and will come out quite easily. However, it relies on not having complete encapsulation of the device. And so what we can see from this is in this study, 40 successful micro retrievals and 66 successful nanostim and a small number that were unsuccessful. So in conclusion, I believe there's increasing levels of evidence base surrounding leadless pacemakers. Currently, most of this relates to micro because of the significantly greater number of devices implanted. But what we can see from this is good evidence of safety, good evidence of efficacy, and there's emerging clinical indicators for the benefit in specific patient groups. Further evidence is expected related to those new devices, the Boston Empower device and the Abbott Avere device. Thank you.
Thank you, Dr. Roberts, for that fantastic overview. I'm going to move on to Dr. El Chami, and then, if that's okay, ask some questions to both of you, because it's certainly prompted a couple of thoughts in my mind. So delighted to welcome Dr. El Chami from Atlanta in the US, also being extensively involved in the micro program and implanting these devices for a number of years. And he's going to follow on from that talk to discuss really the future horizons and where this therapy is going in the future. Dr. El Chami, thank you.
Thank you for the opportunity to be part of this symposium. It's a pleasure to be here. After this great lecture by Dr. Roberts, I'll be discussing future directions with leadless spacing. These are my disclosures. So where do we stand so far with leadless devices? More than 100,000 Micra are implanted worldwide, probably around 150,000. Dr. Roberts touched on the Micra AV and the multiple clinical trial behind the data for Micra, the Micra post-approval registry, which plan to follow up patients for 9 years. So we'll have long-term follow-up. The Micra CED, which is a Medicare mandated study recently published. And as Dr. Roberts mentioned, we currently have the Avere dual chamber leadless device in clinical trial and the Empower leadless device communicating with an SICD also in clinical trial. And I'll focus part of my presentation today on the WISE CRT, which is a leadless device that provides cardiac resynchronization therapy. So this is a quick comparison between the different available leadless devices. As you know, the 2 FDA-approved devices are the Micra and recently the Avere single-chamber ventricular device. The major differences are really in the fixation mechanism, 2 relying on tines and Avere relying on helix fixation. And this is a quick picture. You could see that with Micra and Empower, the tines are fairly similar. But with Avere, it's predominantly a helix-based device. So far, we have 2 approved devices to provide single-chamber ventricular pacing. And obviously, the next step in terms of future consideration is to move into a dual-chamber pacemaker, which is currently in clinical trial. But the next leap in the progression of these leadless devices is to move into a leadless CRT device. And the device that's currently most mature in terms of providing cardiac resynchronization is the WISE CRT system. And let's talk a little bit about the Atrial device. So far, no clinical data is available. It's predominantly data in animal studies. The Micra Atrial device was attempted in animals, and you can see the atrial Micra has slightly different tines. They're more shallow to avoid perforation because the atrium is more thin structure than the ventricle. And in this study, they've investigator implanted atrial Micra, then later extracted it and implanted another one, and histology studies were done. And you can see here the old Micra location where it was extracted and then new implanted Micra. And in this study, it was hard to balance the risk of perforation versus the risk of dislodgement. And 2 out of 44 tines have shown evidence of epicardial perforation. This device is currently on hold and no human studies have been published. The second device is the atrial device from Abbott, Avere. The preclinical safety and electrical performance have been published earlier this year. And in this study also successful implantation in 10 sheep was performed. This device is a little bit different. It has 2 helix fixation, one an inner helix, which is electrically active, and one an outer helix, which is a fixation helix. And in this study, there was no dislodgement or perforation. And as mentioned by Dr. Roberts, the dual chamber Avere leadless device is currently undergoing IDE clinical trials in the US and Europe. When you talk about leadless devices, it's important to minimize the number of devices in the heart. After all, that's why leadless systems have been developed to avoid a lot of leads inside the systemic venous circulation and inside the heart. So maybe a modular concept of pacing with leadless system would work best. For example, if you have a pure sinus node dysfunction, you can eventually put it just simply leadless atrial device. And if you have someone with both sinus node and conduction system disease, you might end up putting a dual chamber leadless device. And if you need to upgrade from one system to the other, you can add the needed piece. So if you have someone with sinus node dysfunction that eventually develop complete heart block, you can add the ventricular device. And you can add the leadless AV, like the Micra AV. You can use it in selected group of patients with complete heart block and intact sinus node. So The next step after a dual chamber device, and soon, hopefully in the next year, we'll have human data on the dual chamber system. The next step is to move into a CRT system. And as I mentioned earlier, the most mature system right now on the market, which is still undergoing clinical trial and it's not approved but in Europe nor in the US, is the WISE CRT system. The WISE CRT system is comprised of a transmitter, which basically detects the pacing from another device that paces the right ventricle. And it transmits ultrasound energy to an electrode implanted endocardially into the left ventricle. And this electrode basically converts the ultrasound energy into electrical energy, providing resynchronization therapy. This is device, the original device was designed to be implanted retrograde via an aortic approach. And right now, we, at least in our center, we implant it mostly via the transseptal approach. So what are the advantages of the WISE CRT system? Obviously, being leadless is a big advantage, with all the advantages that Dr. Roberts mentioned: low risk of infection, low risk of dislodgement. Another advantage is the fact that it provides endocardial LV pacing. As we know, coronary sinus pacing is epicardial LV pacing, which is less physiologic. And as I'll show you, it has the potential for conduction system pacing or left bund branch area pacing. So let's review some of the trials on the WISE CRT system. The original study or the original experience was published now 9 years ago. And it was a proof of concept. 3 patients implanted successfully had significant improvement in ejection fraction from 23 to 39%. Obviously, these were patients that were candidate for resynchronization, but were not eligible for a typical CS lead. And all these patients had improvement in New York Heart Association. The second study is the SELECT LV study that was published now in 2017. It was a small study, but it was a proof of concept again. 34 out of 35 patients successfully implanted, and CRT was achieved in the majority of these patients, 33 out of 34 patients. Like any new technology, while the implant success rate was high, there was a high rate of adverse events. And we see this in many new technologies when implanters don't have enough experience with the device. But if you look at the complication, the majority were femoral access complications, femoral fistula or pseudoaneurysm, because this is a 12 French sheath that insert into the femoral artery. And if you look at the improvement in heart failure parameter with this device, you can see there was significant improvement in ejection fraction. There was significant reduction in end systolic volume and end diastolic volume, and significant narrowing of the QRS. And when you look at the clinical composite score for improvement, 85% responded to WISE CRT. And when you compare this to improvement seen with coronary sinus pacing or typical CRT, the improvement is typically between 50 and 70%. Again, this is not a randomized head-to-head comparison, but at least it puts into perspective that this device can provide resynchronization and have at least similar clinical benefit to traditional CRT. The second study was the largest study. It was a real-world experience with the WISE CRT system, predominantly from Europe. It's a 90 patients. YV pacing was achieved in 94%. And in this study, the first description of the transseptal implant was done. 10 out of 90 patients had transseptal approach for implantation, and that's what we use mostly in our system in the few cases we've enrolled in the clinical trial. And again, high rate of complications seen with this new technologies. 4 of those complications were arterial access complication, but there was also 2 cases of cardiac tamponade. The SOLVE CRT study is currently a study in the US. It's a randomized study looking at the effect of this therapy, but it has a roll-in phase and this phase is non-randomized. And the original data has been recently published. 31 patients successfully implanted, 3 complications, 1 dislodgement, the device was snared out, 1 infection of the generator or the battery, and 1 device lost capture. But I think the exciting part of this device is the ability to provide a totally leadless CRT system. And the early European experience was recently published in EuroPace last year, where it took small number of patients, 8 patients, implanted with a Micra and YCRT system. And as this X-ray showed, the Micra here labeled in green, and in purple is the small electrode of the YCRT. And you see this is the transmitter, and this is the battery. And in this study, mind you, it's a small study, but it showed significant reduction in QRS duration from 200 millisecond to 137 millisecond. EF improved by 11%, and there was a trend toward reduction in systolic volume and diastolic volume. So another important part of leadless devices now that we're hitting an era of conduction system pacing. Are these leadless devices ever able to engage the conduction system? Look, this is the 3830 lead, which is typically used to pace the left bundle. It's basically drilled into the interventricular septum around 1 centimeter to engage the left bundle branch. And as we know, we typically tend to place these leadless devices into the interventricular septum. The problem is, at least with the Micra right now, the tines, even though they are more than 1 centimeter, they don't penetrate the septum. They actually fan into the septum. Plus, they are electrically inactive. So with the Micra right now, with the current design, there is no way to engage the conduction system in the interventricular septum. Similarly, while the Helix might be a better prospect to engage the left bundle, this is a big device. The Helix is electrically inactive. You cannot drill this device with a big diameter into the septum. So modification of the system, of the leadless device, might allow us to provide left bundle branch area pacing. If you look at this picture of the conduction system and the way we pace the left bundle, right now we engage it from the right side, the interventricular septum, and the left bundle is deeper. So you have to penetrate the septum at least by 1 centimeter. But if you think at the YCRT system that we put in the LV, the left bundle is more superficial on the left side. So this device does not have to penetrate the septum for more than 0.5 centimeter to engage the left bundle. And actually, investigators from the UK have looked at the technical feasibility of leadless left bundle branch area pacing to provide CRT. And this is a case with a RV pacing with a wide QRS. The investigator put the electrode on the lateral LV, where is the best area to provide CRT. You narrowed the QRS successfully. But if you put the electrode into the left bundle branch area, into the septum, the QRS become extremely narrow. And these investigators did hemodynamic measurement, and you can see that the improvement in cardiac output was highest if you put the electrode in the lateral wall or the left bundle branch area, 34% improvement in hemodynamics. This is another case. It's an image courtesy of Dr. Olivier Pillot. This is a device implanted via the transseptal approach, targeting the interventricular septum. And here you're anchoring the electrode to the septum. And then you detach the electrode into its final location in the interventricular septum. And this is the final picture. And most of these implants are done either under intracardiac echo or TEE guidance. And you can see where this electrode is. It's in the left ventricular outflow tract. And it's engaging the basal septum, right where all the electrical system emerges to engage the left ventricle and the right ventricle. And this is the intrinsic EKG with a wide left bundle. And the YCRT pace, the QRS narrowed, and you see T-wave memory indicating that you're capturing the conduction system. So there is potential benefit for this therapy, the YCRT, to pace the left bundle branch area. And there's a study going on led by Professor Rinaldi from England. So there is, however, important challenges as we transition into multi-chamber leadless pacemaker. The biggest challenge I see is safety. Dr. Roberts mentioned the importance of perforation with a single chamber leadless device. And while the perforation rate with a leadless device, at least with the Micra, has leveled as around 0.7 or 0.8%, I think perforation with leadless devices might be more serious. And if you look at the Micra studies, 15% of all perforation needed rescue cardiac surgery. In the recently published AVEIR study, 2 out of 3 perforation needed rescue cardiac surgery. So that's important to keep in mind. And the big question is, what is the anticipated perforation rate when you move from a single chamber to a multi-chamber leadless system? Is it going to be double? Is it going to be 1.5 higher? Still, we have to make sure as we transition into a multi-chamber leadless system that this is going to be safe. The second challenge is management at ERI as we hit battery replacement. Because if you imagine you have an atrial and a ventricular leadless device, or an atrial, an RV, and an LV device, there's time where each battery might hit end of life while the other part of the system is still functioning. While some companies market their device as extractable, those of us who do extraction know that extracting every device is not reasonable, and most importantly, is not safe. But I think down the road, as we move into a rechargeable battery, the rechargeable battery might be the answer to this challenge. So in conclusion, we are moving from a single lead to a multi-lead leadless system, and we have a dual chamber system in an IDE trial. Soon we will go into a CRT system, but we're hoping that physiologic pacing with leadless device could be the future, as it will minimize the number of devices inserted into the heart. And maybe the presence of a rechargeable leadless pacemaker could solve many of the challenges faced by this technology. Thank you.
Fantastic. Thank you very much, Dr. El Chami and Dr. Roberts, both fantastic talks. There's a lot of thought-provoking things that come to mind, actually. So I've noted down a few things, and I'd be interested in your opinion. Firstly, Dr. Roberts, you mentioned obviously some of the challenges with deployment and making sure that you don't have to deploy a number of times. As a relatively new micro implanter myself, I'm just keen to know, are there any particular tips and tricks from your experience to ensure that you do get it right first time? Obviously, you can't all of the time, but anything specific you've noticed in your kind of clinical experience?
So I think that with the micro device, you need to have good tip pressure on the delivery tool on the endocardium. If you've got good pressure there, then there's good evidence that the tines will go out and will grip the micro to the endocardium very securely, and that will lead to good electrical pacing parameters. So you have to ensure that you're in a safe place to apply that tip pressure. And so it's very important that you're on the septum. And many of us think that we know that we're on the septum, but unless you introduce contrast down the delivery catheter, you won't know that you're on the septum. So I really believe that it's important that you make sure that you delineate that you are on the septum with contrast. And then once you are on the septum, you're able to exhibit more pressure from the catheter, and you need to see that catheter flexing significantly to show that you've got good pressure. I believe if you spend a little bit of time in ensuring that you're in a safe place and applying that pressure, then you're more than likely to just require one deployment.
I certainly think that being able to cumulatively assess how much is too much pressure and how much is not enough is something obviously that takes time. Having done a number of implants, but not that many, that's the bit that I found the most challenging, and trying to assess whether you have enough gooseneck or not. But that's very helpful. And Dr. El Chami, you mentioned, you touched on the atrial leadless pacemaker and the design of the tip loops or the tines rather than the fixation mechanism. Do you think that we obviously don't know yet, but do you think we're going to see more potential complications with the atrial delivery system? Obviously the Avir is out. The Micra will be, I'm sure, soon. They are different delivery systems, and the atrial we know is a thinner walled structure. So you just have any comments about that and the actual deployment of the system?
Yeah, I mean, that's the big concern I have personally. The atrium, as you mentioned, is a very thin structure. And with this device, the biggest advantage of a Micra really has been almost very low rate dislodgement rate, less than 1% dislodgement rate. But for the atrial, there's a fine balance between minimizing dislodgement and causing perforation. Obviously, if you want to minimize dislodgement, the perforation rate goes higher and vice versa. With the Avir, at least the preclinical data seems encouraging, but they have this dual helix system that seems to minimize the risk of dislodgement. I'm still waiting to see what the perforation rate would be, because assuming it's 1% with the ventricular device, what is it going to be when you go in to put two devices and you're moving, you don't get good threshold, and then you move the device into a second location? I think we're going to get to a point where we say, what is the acceptable perforation rate with this pacemaker? Typically we do transvenous devices, perforation rate is less than 1%. These perforation typically all resolve either conservatively or with draining percutaneously. It seems that with these leadless devices, due to the delivery catheter, the perforation rate is more consequential for sure. I think the next year we'll know more with the IDE study.
Yep. And just moving on to talking about extractability, and you touched on that. I think it's a really important point because the acute and medium-term data is clearly very good. Everyone's seen that, and it's a kind of no-brainer from that perspective. The thing that I think there are lots of questions about are extractability medium to long term, and you commented actually on some of the nanostims that weren't able to be extracted, but also if you end up replacing devices. And if you end up replacing devices, how many can a chamber take? I know our groups looked at modeling and whether you can fit 2, 3, or even more, and whether that has an impact on the function of that chamber, whether it be the atrium or the ventricle. I just wondered on both of your thoughts actually on that, and where we sit now and what's the projected direction of travel.
So if we look, I think you have to distinguish the Micra and the nanostim devices, because the length of the devices is quite significantly different. And so I think that affects endothelialization. So I think there's good evidence that with the Micra device, that once you get out to about 12 months, in most cases, it will be fully endothelialized. So with our current retrieval mechanisms, I think it's going to be difficult to extract those devices much beyond a year. And the anecdotal evidence supports that. So we'll need new technology in order to be able to extract those devices. The nanostim device may be slightly different because the endothelialization may not completely encapsulate it, but we don't have enough data to support that at this point in time. So my view is that what we've seen in terms of the modeling is that the normal human right ventricle can take 3 Micra devices without any significant impairment to right ventricular function. And for most patients, that would be enough if we're looking at a projected battery longevity between 10 and 15 years. So that would give 30 years of pacing. And you could then move to a transvenous system if you wanted to. But like Mikael, I really believe that rechargeable batteries is the way forward with this technology.
I totally agree with Dr. Roberts. One thing I'm cautious about, really, if you don't need to remove all these devices. I mean, the only time when we remove devices in our practice is if there's a suspected infection, which is extremely rare, or if there's an acute or subacute increase in threshold, the device has been in there for a short duration of time. Really, what are the indications, or what is the push to remove these devices when they've been implanted for 10 years and it's time to change the battery? I think if you weigh the risks and the benefit, you probably should leave these devices alone.
Yeah. Okay. And can I just move the discussion on and ask you about, we didn't touch on it in the talks, but the AV synchrony and the VDD sensing of Micra, the AV Micra, Mass and Marvel. There's obviously some good data that's been reported. I know just from anecdotal experience and some patients when they exercise, and from the studies, there's a suggestion of the loss in that AV synchrony. Do you both think that the technology as it exists now, clearly it's going to move in a certain direction with an atrial leadless system, but do you think that that is an acceptable technology going forward? Or do you think that we do absolutely need a leadless atrial system to go with a ventricular leadless system?
So I don't think it's a perfect system, the AV Micra, and I think there are some challenges in getting the AV synchrony set up with individual patients on a case-by-case basis, and there's a learning curve to achieving that. The device very deliberately mode switches to VVI with exercise because the intervals all start to shorten down with short RR intervals, and the added noise with exercise means the ability to detect that A4 signal representing atrial contraction reduces. So the argument is that with exercise, we rely more on rate rather than AV synchrony. I think we probably ideally need both. So I don't think it's a perfect solution, but it's a pretty good solution with just a single chamber device. And I think that as the technology moves on, we will need atrial pacing, and the AVEIR device is the first step in that direction.
Yeah, I think the key to the Micra AV is patient selection. If you have a patient who's an avid exerciser who just gets on the bike and is competitive, the Micra AV, like such patients with congenital heart block, they're younger, they're healthier, they're more active. They're not going to do well with a Micra AV. But your average complete heart block patient, the 80-year-old, the 78-year-old, the 82-year-old, that device might be perfect for them. Because between 60 and 100, the AV synchrony is very acceptable in the majority of these patients, but as they exercise or move, they probably don't need their AV synchrony as much. So that's why I think with the Micra AV, patient selection is key.
Thank you. And if I may, I just have one further question regarding the algorithms and battery power. So we know that over years, the industry have made obviously numbers of iterations and developments within the current transvenous models, and the algorithms that exist take time to iterate and drain battery. Particularly, we know that wireless energy and transmission drains energy as well. How long do you think it will take the companies, when we have a dual leadless system in place, to be able to replicate what we have in a transvenous model? Because clearly there may be a shortcoming there with respect to certain algorithms that we have in the transvenous systems that we may not have if we completely disrupt and move to a leadless dual chamber system, if you see what I mean. So
I think that's a really good point, and the units in effect work separately. So the whole sort of sensing is very different, and if there's communication between them, then that is going to be a significant drain on the energy requirements. And I think that one of the greatest challenges is the fact that there will be variable drain on two devices. And so when it comes to generator change, that will be potentially complicated with the need to add a further atrial lead in, but on a ventricular device, and vice versa. So again, I think that this lends to itself to the only way forward with this is looking at not relying on conventional battery technology. It may be rechargeable, there may be an element of energy harvesting to prolong that, but for sure that it's going to be some significant period of time before two individual devices are able to compete with all the physiological parameters and algorithms that we have in our current very mature platform of dual chamber pacing.
Yeah, I totally agree with Paul. I think a change in battery technology is needed to optimally use these leadless devices. if we want to have all the bells and whistles of traditional transvenous device.
Yeah. Completely agree, and I think you touched on it in your presentation. The leadless, the wide CRT system that we've had quite a bit of experience at St Thomas's and elsewhere, I think does offer some of that with respect to CRT, but clearly battery had been an issue as well. So I suspect you're right in that the battery chemistry design, the rechargeability going forward is going to be the rate limiting step at unlocking that technology going forward. Fantastic. Well, thank you both so much for enlightening talks and a fantastic update in this exciting area. I hope that those watching find this instructive and useful. Thank you very much to the Arrhythmia Academy for hosting and Radcliffe for supporting. Thank you both very much.
Thank you.
Thank you.